Okay, we're going to make a little bit of a transition here, and we're going to cover really another quite timely and exciting topic. Many of you attended our launch event for Illumia Health on March 20th. As a quick reminder, through full risk, we can offer high-touch, in-home care at no cost to our eligible patients. So those are our Priority Health, BCN, and Blue Cross Blue Shield Medicare Advantage patients who meet the criteria as having 12 months or less of life expectancy. The scope and level of service are so differentiated from what we previously called palliative care that we are calling this advanced illness management. What this means for your patients is they will have a minimum of 2 in-home visits monthly from nurse practitioners to see how they're really doing when they're not in your office. It means telephone support from nurse care managers and social workers in between visits. It means having a nurse come to the patient's home at 2 a.m. if need be for a symptom crisis. If it turns out that that patient really needs to go to the ER, it means having that nurse who knows them accompany them to the ER to provide a warm handoff and advocate for the patients. This is a proven model already working in 9 other Agilon markets across the country with clear positive clinical outcomes. Providers in these markets are thrilled with the level of care their patients are receiving. So this is a true win-win scenario for our patients and Senior Health Connect. It represents our single biggest opportunity for cost savings. Since we spend 6 to 8 times more on healthcare services in the last 12 months of life, by reducing avoidable ER visits, hospital admissions, and facilitating appropriate hospice transitions, we can have a dramatic impact on medical expenses and help keep patients in their homes where they want to be. So with that backdrop, how's it going since the launch date on April 9th? Well, Answer Health PCPs have already submitted almost 90 referrals to Illumia. We're absolutely thrilled with the early engagement in this new partnership and believe it really speaks to the value of this partnership that we can offer our practices and the patients we care for. I'd really like to thank our colleagues leading the way who've already referred patients to Illumia, some of them many times already. As we'll discuss today, these early referrals are extremely valuable not only for the individual patients in whom time is of the essence, but also in getting this program off the ground and ensuring Illumia can deliver the excellent clinical outcomes and value to our PCPs in 2025. You can see that actually the number is closer to about 40 now, so it's higher, a little higher than this slide here, the referrals that have converted into enrollment so far. And we expect that many of these pending patients will also enroll. We've had a small number of patients who have not been taken under care for one reason or another. We'll talk a little bit about that. So 6 patients have refused services, and that's fine. In these cases, Illumia will have communicated back to the referring process what occurred so that the practice can follow up with the patient if they would like to. And 2 of the patients were deemed by Illumia to not be clinically eligible for the patient yet. Again, this is okay. One of those patients was actually somebody I referred. He was a guy with frequent falls, Parkinson's disease, has a VP shunt in place, currently compensated coronary disease and diabetes that didn't currently meet criteria. So I spoke with the nurse practitioner who did the assessment and then to his wife and really explained to her that this is actually kind of good news for a patient. And we can always ask for another evaluation if and when he further decompensates clinically. So finally, I'll highlight the 15 patients or more that Illumia is still reaching out to. When you fax a referral over, Illumia will reach out to the patient within 24 hours, and then they'll try 3 separate times to reach the patient. And this is where we can really help Illumia by ensuring that we've obviously first had a good conversation with the patient, explaining what it is, and also sending the referrals over promptly with best contact information. And really ideally, using direct scheduling, which sort of offers a shortcut around all of this, and we'll talk more about this later. So feedback from the Illumia staff continues to be very positive. Patients being referred are clinically appropriate, and patients have received a good explanation of services prior to Illumia's outreach. We're working on weekly reporting to show practices the status of all referred patients. This should be ready, we're hoping, in the next 2 weeks. But in the interim, if you have questions about the status of a referral, you're welcome to contact Illumia or Matt Webb for an update. So finally, if you've had a patient enroll, you're likely to start seeing progress notes arrive soon. I've gotten several already. Typically, Illumia will be sending these out within 24 hours of completing a visit. However, early on, all progress notes are being reviewed to ensure that the documentation is up to Illumia standards, and that's just another example of the rigor behind this program. So, as I said previously, super excited about the number of referrals so early into the partnership. We've been encouraged further to see that these referrals have come from almost 40 unique PCPs at 20 different practices. You can see on the graph on the left, we've had a handful of PCPs who have already referred 5 or more patients. But you can also see those, the red bar, and that's the 112 PCPs who have not referred anyone yet. In the graph on the right, you can see that after the initial bolus of referrals, that they're leveling off. This isn't really, I don't think, a cause of concern, but it does show us that the early adopters have already adopted the program, and now we need everyone else to give it a try also. So as I said at the March 20 kickoff dinner, we're all in this partnership together, and we need everyone to engage in this program or at least give it a chance. Getting patients enrolled as quickly as possible does really 3 things for us. And first, and this just goes without saying, it connects our vulnerable patients and their families to this care as soon as possible. Dr. Copeland said it well at our launch dinner. The patients we refer to this program are those we believe have a life expectancy of less than 12 months. If we wait until August to refer this patient, for example, we've let them go 1/3 of their remaining life without a resource that we believe can demonstrably improve their quality of life. Second, the sooner we get patients into the program, the sooner we're able to start seeing improved clinical outcomes and sharing those with the network. It's also just being a good partner to Illumia as they've staffed up fully to accept the volume of patients expected to be eligible so that they can ensure access. And third, as I said before, and I think this bears repeating, this is our single biggest chance to meaningfully impact avoidable ER and inpatient admissions, reducing medical expense in 2025 and creating opportunity for shared savings and reinvestment back into our practices. So with that said, I'd like to again thank those of you who have referred patients already and ask you to talk to your colleagues about your experiences and encourage them to refer a few patients if they haven't already. So now I'd like you to hear from one of our colleagues who's referred several patients and already experienced firsthand the value that Illumia can offer just 2 weeks in. So that's Dr. Deirdre Quinn from the East Paris Internal Medicine. Deirdre?
Thanks, Dave. As Dave said, I'm Dr. Deirdre Quinn from East Paris Internal Medicine, and I'm also a pod leader. When we collectively agreed to become a risk-based entity, we agreed to continue to provide what we were known for, which was high-quality medical care as being a part of Answer Health. However, we also assumed financial responsibility for the medical care of our patients. And we're very fortunate that we now have a clinical program that aligns with these goals of good, high-quality medical care and fiscal responsibility. However, this program only works if we utilize it and refer people. Remember, it's an extension of our office designed to be proactive in treating early decompensation by your patients quickly and in the home to avoid ER and hospitalizations. I have 2 examples I'd like to share with you, but first I'll give you a little bit of background about our referral process and who we referred. So prior to the kickoff, East Paris had identified 8 individuals that we felt would be a good match for the program. We followed up with all 8 of them, and we followed up with Illumia. And universally, the patients that embraced the program have been very grateful and pleased with it thus far. They like the fact that it's care in the home, and they like the fact that the focus is on prevention of ER visits or hospitalization. And an icing on the cake is they like the fact that this is a covered benefit and is not costing them anything. In our office, how it works is we talk about the program with the patient. I then do a warm handoff to our care manager that comes in, reiterates the program, calls Illumia, gets the patient an appointment right then and there, and the patient leaves our office with an appointment. We've found that when this occurs, there's a warm handoff and they leave with an appointment, the patient is going to meet with Illumia. So my two examples are, I have a 92-year-old gentleman who looks terrible on paper. He's got coronary artery disease, valvular problems, congestive heart failure, hypertension. But the main medical condition that has him end up being hospitalized is he has open wounds on his legs from venous stasis ulcers that become infected. So on paper, he looks terrible. However, he continues to live independently and he continues to travel south for the winter months. This past winter, he left at the end of December and came back at the end of March, and he had 3 separate hospitalizations when he was south because of infections in his wounds. When he returned to Grand Rapids, he was evaluated in our office. The program was discussed with him and he was eager to give it a chance. When the Illumia nurse practitioner went in, during her assessment, she determined that the gentleman again had a developing cellulitis. She called our office. She talked to the care man. Before she called our office, she actually prescribed antibiotics. She called the wound care office, of which he's already established with, and had his wound care appointment moved up. And then she called our office and let us know what had transpired. I'm happy to say that so far he has remained in his home with his cellulitis being treated with oral antibiotics. My second example is an 85-year-old diabetic, congestive heart failure, hypertensive individual who, through the Burden of Illness program, has been identified as being a high-risk patient and in need of advanced illness management. I see her every 90 days with her daughter. Her daughter is one of 7 siblings, but the one daughter is responsible for the medical care of her mother. She was in last week and I brought up the program with them. The patient turned to her daughter and said, "Vicky, do you honestly think I need this? Because I don't feel I do." And Vicky looked at her mother and said, "Mom, I need this program. If you don't think you need it, I need it, because you place me into a position of having to make medical decisions about whether or not should you go to the ER or not." So they signed on with Illumia. 2 days later, the nurse practitioner went into the home. The night before the nurse practitioner went in, the patient had a fall. The patient didn't call the doctor. She didn't call us. And she waited for the Illumia nurse practitioner because she knew she was coming in the morning. The practitioner found that there wasn't any major trauma. There was just some bruising, but she did note that the patient was hypotensive. So she called our office. She talked to our care manager. The care manager caught me between patients. I made medication adjustments with regards to her antihypertensives. Our care manager talked to the nurse practitioner who was still in the home, sorted the patient out with the change in meds, sorted out her pill box, made sure she understood the instructions, and the patient has remained, hasn't fallen again, and has remained out of the hospital. So I think both of these examples nicely illustrate proactive care in the home and avoiding ER and hospitalizations. However, again, this program only works if we utilize it, and it will only be available.
Deirdre, you're muted.
Oh, sorry. So when did I get muted, Dave?
You said it will only work if we use it.
Okay, so the program is only going to work if we utilize it, and it will only be available to us if we use it. So our ask of you today is to please consider it. It would be ideal if everybody that's here today made one referral today. I can tell you, I've seen the progress notes that have come back. They've been very high quality, and I've been pleased with the documentation that has supported the visit. So again, our goal is for everybody to utilize the program. Thanks, Dave.
Thanks, Deirdre. Just a reminder, if everyone could mute, that would be helpful. Okay, that was very helpful. Thank you again. Next, I kind of want to highlight a few best practices for referral, starting first with how we can create an opportunity to refer a patient to Illumia. So while it's important for PCPs to discuss Illumia with a patient prior to a referral, you really don't have to wait for an office visit. I had several patients that I discussed the program with prior to the launch date. Then I asked my MA to call them after April 9th to remind them about Illumia and our conversation, and to let them know to expect a phone call from Illumia to schedule the evaluation. That way I made sure that they actually answered the phone when they got the call and got scheduled by sort of prompting their memories about our conversation. Other providers are calling their eligible patients on the phone, explaining the value of the program for them and their families. I mean, it kind of goes without saying, patients love to hear from their providers and really appreciate the personal phone calls, especially when it's on something so important. And this actually can free up time when the patient's in the office, since you've already discussed it with them. As many of you know, sometimes these conversations take multiple attempts until the patient or their families are in the right space for it. Even if they decline the referral initially, there will be a level of familiarity with it if and when you decide to discuss it again in the future. So for patients with whom you're able to have the face-to-face conversation about Illumia, we strongly recommend direct scheduling that I alluded to earlier. This simply refers to calling Illumia and scheduling a patient's consult visit before they leave your office. It just takes a few minutes, and it's been shown in other markets to dramatically increase enrollment rates. It also improves patient confidence in the program and immediately closes the referral loop for your practice, which saves time if there are any referral issues. So in my office, we have somebody named Audra from our referrals department who does this. After talking with the patient and getting their agreement, I simply walk down to Audra's desk. She comes with me in the patient room. She calls Illumia directly, and the patient leaves with a time and a date for the evaluation. Patients love this as it avoids the potential for phone tag, and Illumia is getting, at least now, my patients scheduled within 1 to 2 days. I see this kind of as a no-brainer, and it was really a fairly easy process to set up. And lastly, remember that even if you do the direct scheduling, your office still needs to fax the referral documents over, so that the Illumia provider can know the clinical situation prior to going into the patient's home. So you've got the patient on the phone, or they're in front of you at the visit. How do you actually bring this up? So in my own experience, it maybe took a few times to get comfortable with having the discussion, but I've since found that these conversations are not very difficult or overly long, and it just really isn't a hard sell. So my recommendation first is just to keep it simple. I don't use words like palliative care. I often don't talk about their prognosis. This is usually going to be a continuation of a conversation I've been having with the patient for some time now, about challenges they've been having medically, such as recent hospitalizations, frequent ER visits. I position Illumia as an extension of my practice, and I talk to them about how they're going to help me take better care of them, to get better control over whatever symptoms they're struggling with, and help them stay out of the hospital and in their homes. I let them know that this is an incredible service at no charge to them, and mention the in-home visits, the availability of social workers and nurses, the Call First program for the 2 a.m. inevitable health crisis that will get an actual nurse to come and assess them in their homes. That usually is enough for the patient. And as Deirdre mentioned, oftentimes maybe for the family members who are doing a lot of this work themselves and they're just exhausted. I let them know that I am not going away, that Illumia is an extension of me, and we will be collaborating together to get them the best possible care. I emphasize that I will ask one of my Illumia colleagues to come in and do an in-home evaluation to see if they're candidates for the program. Then, if they're in agreement, I initiate the direct to scheduling that we just covered in the prior slide. So the timing of this launch, of this partnership worked out really well, I think, as it ties nicely in with our quarterly active panel management or APM activities. And recall, this is where we are reviewing our high-risk patients, and we look at things like how often we're seeing them, what resources we have in place or could be added. With Illumia, we have a fantastic new resource for our patients. And these lists are a great starting point when we think about which of your patients could benefit. Many of you met with your pod leaders sometime during the February to April timeframe for an APM meeting. You know, we tried to work ahead and identify appropriate patients for those, but it was really kind of hard when many of us still had limited information about Illumia and what it would actually do for our patients. Now that we know what it is and what to expect, I think this exercise is going to be even more helpful. The key in these meetings is going to be turning the decisions made into action. So once you've identified patients with a limited life expectancy, work with your teams to ensure that they get scheduled or set aside some time to call them and make a referral. I realized that I missed a slide here, and I'm really apologize. But I think it is important. So I actually am going to go back. And again, I'm sorry about this. So there may be some redundancy built in this slide, but I think it's important to key in on a few things. So once you've referred the patient for an evaluation or consult to see if they're a candidate for the program, a couple of things I want to say. So first of all, the patient isn't committing to anything. You do not lose face if the patient isn't eligible quite yet, as I mentioned with my patient. There's really nothing to lose. Again, as I've said several times, and Deirdre said, you're still the PCP. Patients will continue to come and see you, but Illumia will be there to check in on them in between visits with you and make sure the patient's doing okay in the home. The patient knows that you're not going anywhere, and that Illumia is an add-on, value-added partner to help you take care of them. Illumia is available overnight. They're available on weekends, whenever the patient needs help. The patients can call them 24/7. So my office, and I'm sure yours, have triage after hours, but Illumia can actually come into the home if needed and hopefully prevent necessary ER visits. And then they'll let you know what's going on, as Deirdre shared with her patient. The no-cost piece really doesn't require additional explanation. And then I think we always tie this back to the patient's goals. What are they? Is it feeling better? Is it staying out of the hospital, staying in the home? Is it support for the family or caregivers? We can obviously tailor this to the patient and their unique set of issues, but the larger point is that Illumia can help them both identify and meet those goals of care. And again, as I mentioned, we'll be talking about this more in the APM activities. So in summary, there's several asks that Senior Health Connect leadership would like to make of all providers. First, please make sure to fully and completely fill out the MIP forms and use them and use as complete and accurate documentation as possible. Next, you will also be seeing recommendations for stage B heart failure on patients with risk factors and evidence of structural heart damage. The earlier we identify these patients and get them on appropriate goal-directed medical therapy, the more likely we can delay, if not prevent, their progression to symptomatic heart failure. And lastly, I do want to reiterate my request and that of Deirdre's from earlier, which is to give Illumia a chance. My specific ask is that you enroll at least 2 patients that you think would benefit and follow along with their experience. I know that you will come away impressed. Then I ask that you discuss this with your colleagues as you see and experience how this is helping your patients and their family. And if you're listening this morning, you still have reservations about Illumia, I encourage you to go back and listen to Dr. Copeland's testimonial from our kickoff dinner March 20th. He's a primary care doctor in Detroit, and they've been working with Illumia the past year with really exciting results. And the link is noted in this slide. Finally, remember, you get credit for attendance today by scanning the QR code on the right here. And now I will open it up to any questions that you might have. Thank you for your time. Pam, would you like to lead this portion?
Sure. Looks like we have a question. Jeff Williamson?
Yes, good morning. I've had a really good response with Illumia, and certainly I have insight to it as well. But from a primary care standpoint, one of the questions that came up for me was, how does this work with our touches, and how do the touches from the nurse practitioners and the nurses count to our BOI touches?
That's a good question. I think it's come up mostly in the realm of transition of care, because obviously that is something that we are sort of graded on. And that's where actually Illumia can help us. They will go out, if a patient does require hospitalization, they actually will go out in the home fairly quickly after they come home. But they also acknowledge and they know that it's important that we see the patient as well in the office so that we get the transition of cares done. So they're actually going to also be recommending and sort of strongly advising our patients and maybe helping them to schedule those follow-up appointments in our offices. I'm not exactly sure the rest of the question. As I mentioned earlier, you know, all of the BOI work only really needs to be done for the purposes of CMS, you know, to code each code at least once in a calendar year. So if the question is, will their documentation for an HCC condition count? I'm not sure it will, but again, remember that we're still seeing these patients ourselves in the office, and that's when we're going to be doing the BOI work. So I'm not sure if that answered your question, Jeff. Jeff, maybe you want to explain to everyone who you are and what your role is.
Sure, thank you. Primarily, I am a primary care doctor, as many of you know, in Rockford. Been a member of Answer Health for many, many years, primary care doctor. My partner, Dr. Keller, and I have about 4,000 patients in our practice and about 500 that are on the BOI list that we've been working now for 2 or 3 years. I also am a hospice doctor with Gentiva Hospice, and then we have moved into the role of the Illumia medical director. So when you make the referral and our nurse practitioners for Illumia go out there and see them, they run the case past me, where I'm wearing both hats. I'm wearing the hat of the Illumia medical director to make sure that it fits our criteria for the Illumia program, but at the same time, I'm also trying to think as a primary care doctor, where did this referral come from? How would I have done it? Is there a way that we can improve this step? And working on a lot of those things.
Thank you.
You bet.
All right. Looks like there's a question in the chat by Tori Carlson. Have you changed your proactive lab ordering for patients who have stage B heart disease? For example, now ordering BNP and troponins for patients as a part of criteria for stage B besides the echo results of the past, or ordering echoes proactively?
I think we all need to kind of consider our own workflows. I will not be doing that. I think there's enough work currently with going back and looking at all these echoes that have already been done on patients. This just came up yesterday. I had a patient with a history of hypertension, and on my MIP form, the reviewer had noted an echo actually from 2020, where the patient was noted to have mild LVH, as well as some valvular changes. And so, I was able to kind of give the exact same spiel that I just was sharing with you all about how this actually means that the patient actually has stage B heart failure. But in his case, he was well controlled on an ACE inhibitor. So I mentioned that this actually at present isn't going to be changing his management, but that we are going to be watching all of his risk factors very, very carefully as a result of this, and really just brought it up as a point to say, hey, you're going to notice this on your problem list, and this is why it's on your problem list, and this is the management that we need to be doing for it, and oh, by the way, you're already on that management. I think the role of BNPs should still be that of only if the patient is actually having symptoms, to try to help sort out if this is a heart failure exacerbation or not. There's also the issue of, will be paid for, and typically that lab is not paid for unless the patient is having symptoms. So I'm not sure that at this point it's really changing much of what I do as opposed to me and all of us just being more aware of, what are the ACC-AHA staging and just realization that many more of our patients have stage B heart failure than maybe we're aware of, and we need to really be optimizing their medications. But then in addition to that, there are a lot of patients that probably are actually stage C. So asking those really targeted questions about that I mentioned earlier about going to the mailbox, being in the store, are they having symptoms? Because if they are, they're probably C, in which case their goal-directed medical therapy, it now needs to include a lot more medications than just the ACE or the ARB. And that can be perhaps a case where the BNP might be useful if they're actually having symptoms. So hopefully that's helpful.
All right, another comment in the chat from Jeff Williamson. Just as a point of interest, have been denying many of the recommendations for I-50.9 since we have more specific codes for the heart failure patients. I-50.8, which are C, I will be watching much more closely for the Bs now. And Dave, we just had a conversation about this yesterday. I don't know if you want to elaborate on that.
Yeah, Jeff, that's a really good question because, I don't know if you recall, but when Dr. Singh gave a webinar, I think it was a month or two back, I talked a little bit and I said, sort of tongue-in-cheek, this is sort of like one of the few times where I'm recommending that we use an unspecified code because I've been teaching you the last couple of years, don't use unspecified codes. This is actually a little bit of an exception because some of the other I-50 codes, like the I-53Xs, or like diastolic congestive heart failure, we're really not kind of at that point yet where we feel from a compliance standpoint that those are the most effective or best codes to use. So as of this point, I-50.9 is the code that's going to be recommended and the one that I would like you to use if, of course, the patient meets criteria. So, Jeff, this is an example maybe where I mentioned there's going to be where we're doing this sort of look back. If a code was disagreed with, we're actually having, a human look back and just make sure that the code that was disagreed with actually is incorrect. I mean, if it is, that's fine. But in this case, this look back process would say, hey, it looks like, Jeff, it looks as though this is a valid code. And then typically your pod leader or whatever would go out and kind of do the education that I just provided this morning as to why the I-50.9 is the most valid. And in this case, even though it's unspecified, this is the code that we would like to be used.
Buds in the car and oh goodness.
Any other questions or comments? Just a thumbs up from Jeff Williamson.
Well, if there's nothing else, I think I'll speak for Pam and everyone that we just really appreciate all the work that everyone's doing. I know this can be hard. We all have lots of things we're doing, but I think it is important work so that we can continue to invest in our practices and stay independent, which is all of our goals. If there are additional questions, please feel free to reach out to, I think, really any of us, including your pod leaders. Make use of your program managers for scheduling and those sorts of things as well. And hopefully it came through. I'm really excited about Illumia. I am a big proponent of palliative, in this case, we're calling it advanced illness management, but also hospice care. I think our patients that are most vulnerable need this program. And again, my ask is that think about a few of those patients that are just been in the hospital a lot recently, and it's just really struggling with keeping them well maintained, or their families seem like they need the help or whatever. It doesn't hurt to get an evaluation. As I mentioned, even if Illumia comes out and says, hey, we don't feel like this patient quite meets criteria, they will oftentimes then give us recommendations for, like, we don't feel like maybe we're the appropriate program, but maybe you should try this, that, or the next thing. The nurse practitioners were all hired. They're all in community people. They know our area. They're not coming in from outside. And so they can be a real nice resource if you just kind of feel like you're spinning your wheels on a patient or two. I've sent over a number of patients already and already been pretty pleasantly surprised with good feedback already from my patients. So again, really excited about this. Would like to encourage people to give it a try. Jeff?
Yeah, sure. One other thing that I noticed is both primary care and receiving them. So I had the opportunity, kind of like you did, to make the referral from a primary care standpoint, but then also see it be received from Illumia. I made my first few referrals sending the diagnosis list, patient summary, why we're sending them over. And then the very first thing that we hear from the nurse practitioners are, we're taking over a lot of their care. We need to know more. So instead of a usual referral where you're sending them to orthopedics or cardiology or something like that, we need records supporting the things that we're sending over. So if we're sending somebody with B-cell lymphoma, congestive heart failure, and dementia, the labs, the neurology note, the MRI, the cardiology note, the cancer, the oncology notes are very, very helpful. On the other hand, we don't want the select all, where all the records get sent over like you're transferring care, because we're certainly not. But I'm starting to do a much longer paragraph when I'm sending over the referral. Almost, we're doing the warm handoff on the telephone, but I'm sending about a paragraph of, here's who this person is, here's a case presentation, and here's why I want them on the service, along with the records, and that seems to be working very well.
Yeah, I love that. I think that's a good point. Something that just came up in my office yesterday was sometimes the Illumia folks are having to call back also and saying, hey, can we get their advance directive? So another thing that we should be including, in addition to, like Jeff said, I think this is not a typical referral. This is give them as much information as possible, why you think that, why you want Illumia to get involved, first of all, but also if there is an advance directive in the chart, please send that as well, to save that extra call where they call you back and say you need to send that. So I think just make that as part of your standard protocol, that those are the things that need to be included with the referral.